Good morning. I'm Dusky Cherry, President of ITC Midwest. For the third straight year, we are pleased to be the presenting sponsor for the Iowa Ideas Conference and extraordinarily proud of our partnership with the Gazette. As an electric transmission company serving 2/3 of the state, ITC Midwest is invested in and has a very real stake in the future of Iowa. We've supported this conference since its inception because we embrace its mission of gathering hundreds of Iowans together to explore the key questions and the big ideas that will shape the future of our state. ITC Midwest was formed in 2007 to improve electric transmission reliability and increase transmission system capacity in Iowa. And we followed through on that commitment with more than $4.1 billion in capital investments to date. Our investments in the system not only serve the changing needs of customers, they also provide additional capacities to support economic growth and development of low-cost renewable energy resources. Our investments have resulted in a 62% drop in transmission-related outages since ITC acquired the system and began operating it. From extreme weather events, such as last year's derecho, to the unprecedented transition to renewable energy, from the rapid adoption of electric vehicles to the increasing focus on energy system resilience, the electric utility industry is suddenly in the national spotlight. All of these forces reinforce the critical role of the transmission grid to support the changing landscape and ensure consumers have access to low-cost, clean, and reliable electricity. You know, we often talk about here at ITC about the power of connection, meaning connections are needed to deliver power to communities. There's also tremendous power when people connect to solve problems. Over the next couple of days, I hope you will engage in the breakout sessions, speak up during discussions, and share your ideas to create a brighter future. Open your mind to different points of view as we all work together to come up with the best solutions for making Iowa an even better place now and in the future. I want to thank you for your participation to help shape the future and wish you a great conference.
Well, good afternoon, everybody. Thank you for joining. This is the Mental Health Centers and Resources session as part of the Health and Human Services track. I'm Brian Bush with the Gazette. Want to thank everybody first and foremost for joining, taking a little bit of time out of the afternoon for Iowa Ideas 2021. We're super excited to be here. We've got a great panel with 4 very unique, in-depth, diverse perspectives, and we've got a lot to talk about. So we'll dive right in. Some real quick introductions. Like I said, I'm Brian Bush. I'm with the Gazette. I work primarily with our leadership development program with our Iowa Ideas sponsors, some digital strategy, and then also on our DEI committee. And then I'm also a licensed mental health counselor, which is how I got really lucky enough to be connected with this group here. So Ellen, do you mind if we start with you and we'll just kind of go around, and if you can give us a brief background on yourself, we'd really appreciate that.
Sure. Thank you so much for having me. Yep, my name is Ellen Burbridge, and I'm the community liaison for Eagleview Behavioral Health. We're a new freestanding mental health hospital located in Bettendorf, Iowa, opened up June of 2020. Prior to working at Eagleview, I actually worked in human services, both in resource and referral counseling and peer counseling with caregivers, and primarily or concentrating on older adults, adults with disabilities, and grandparents raising grandchildren.
Thanks, Ellen. Abbey?
Hi, everyone. I'm Abbey Ferenzi. I'm a licensed mental health counselor and the executive director of Guidelink Center in Iowa City. We're one of the first access centers in the state where we offer immediate crisis counseling and triage for people experiencing mental health or substance use issues. So happy to be here.
Thanks, Abbey. Andrew?
Good afternoon, everybody. My name is Andrew McKnight. I'm a police sergeant with the Iowa City Police Department. I also am a lead instructor with the crisis intervention program that we have here in Johnson County. I'm on the board of NAMI, and more recently at work, I've been given the task of embedding a mental health clinician into our department. So I'm excited about that and happy to be here. Thanks for the opportunity.
Yeah, thank you. And Marissa?
Good afternoon, everybody. I am Marissa Ianson, and I work for the Iowa Department of Human Services. My role here is that I'm our division administrator for community, mental health, and disability services. What it means is that I'm our state director for mental health and our state director for disability services. I get to do a dual role. I'm a lifelong Iowan. I've never lived in a town of more than 6,000 people. And this is the only work I've ever done. My first job was working in direct care, supporting folks with disabilities. I've done a lot of provider side work, and then I flipped over into doing some payer work and some Medicaid policy work before I did this role. So really excited to be a part of this conversation today and really appreciate the Gazette lifting the conversation up. So thank you.
Thanks, Marissa. Yeah, like I said, we're very excited to have the four of you here, so very much appreciate that. I want to make one reminder for the audience listening. If you have questions, thoughts, comments, please submit those through the chat. Those will come to us. We'll try our best to get everything really presented to this group. We had a couple of questions come in even before the session, so I know people have a lot to talk about. With that said, let's just kind of dive right in. And Ellen, if we can start with you. We'll really just sort of start at a broad level. I'm curious from your perspective, at the state level, is there a lack of continuum of care? And if so, how do we look at that when we think about things like jail and ER diversion, for example?
Sure. To say there's a lack of, I would say there's always room for improvement. There's always going to be more need, I think. However, I do see things improving, which is fantastic. And I think that is one thing that may have come out of the pandemic that may have been positive, is people being a little more aware of that need. In terms of, I think everyone's situation is so unique that we see, particularly with our patients, for example. It's not just a matter of, setting them up with a psych provider or getting them into our hospital, but it's that aftercare of what happens when they leave our hospital. Yes, they're connected to a psych provider, but is there a roof over their head? Do they have transportation to that psych provider? Are they getting, have availability to the proper medications? In terms of, diversion from places like jail and ERs, I think it's a matter of education and having some of that responsibility on us, those who provide the actual mental health resource, of going out, talking to them about what is available in their area. I know that we have actually hosted a number of new Davenport police officers a couple of months ago, straight out of the academy. One of their first stops of training was coming to our hospital and learning about our resources and understanding the intake process. So I think that's a big part of it, but also just proper communication with ERs and letting them know that, we're a resource where you can go straight to our facility, much like the Access Center, where if there is that imminent need, they don't have to necessarily go straight to an ER first. They can just have that straight shot to us. And we have, tried to work on proper communication with those ER staff, letting them know when beds are available. We understand that they rarely have time to even sit down and have lunch, let alone check their emails. And so daily, we're sending out a fax to all of them, letting them know what beds are available at what time, and how they can make a referral to us. And so I think that's what's really important for that, to have that continuum of care and making a successful plan for patients.
Ellen, that's really interesting. Go ahead, Marissa.
Oh, sorry, Brian. I was just going to say to Ellen that was all so good and so similar to what we see when we think about it from a system perspective here at the state as well. But,
right.
We're fortunate to have some really good investment in our state. Sometimes folks aren't aware of where they can go and what to do. So, a couple of spots that we see, we do think that we probably lack some step up, step down options. Sometimes we see some folks getting stuck in high levels of care and they're not able to get back out. Right. Because there's not a step down in between, or we see them escalating up and like leapfrogging in systems. We see it a lot for kids in particular. Just kind of a vacancy from some of our youth is something that we see just systemically, I think. One of the other spots that we're really paying some attention to right now is, and I think you spoke to this too, it's a bit of a lack of coordination in the service spaces. There's all of these options that are available, but a citizen here in Iowa may not know they're there. And so we're really trying to be thoughtful about how can we do better in those spaces to really coordinate around those options and make sure that folks know what's available to them and how to get there fast.
Yeah, that is interesting. And Ellen, you mentioned a couple of things there that I am curious. Abbey, I think you have some insight into this as well. When you think about, you said that talking about the number of beds available or the impacts of the pandemic, Abby, from your perspective, what impact has the pandemic had from just an availability of care standpoint, and has that shifted how we need to look at things going forward?
Sure. Well, mental health needs were on the rise even before the pandemic, and now with the pandemic has exacerbated many of the mental health and substance use issues that we already had. I agree that there are a lot of great resources available. There's always more work to do, like Ellen was saying, but communicating, collaborating, and coordinating those services and making them easy for people to access. That's what we're trying to do here at the Access Center, because people who are having those issues are going to struggle with trying to figure out how to navigate this, quite honestly, complicated system that we have.
Yeah, and then I think the second half of that I was curious from each of your perspectives on is this whole sort of challenge around staffing. What does that look like right now when you think about the ability to have enough care and enough resources out there? What challenges do we see with that, and what needs to happen going forward?
Right. Well, I think in order for, our facility, for example, to make sure that not only the patient has a successful experience, but a safe experience as well, we do need to make sure not only is that, fulfillment of an RN, for example, there, but it needs to be that person who has that right personality, that right experience. It can't just simply be a warm body with a degree. We can't do that if we want to have that patient to have success. We have been working with a lot of local universities to talk about the various opportunities at places like our hospital or other resources, and really encouraging students to get involved with the mental health field. So I think that I see that the future is bright in terms of a lot of enthusiasm for younger folks to get involved in our particular field. But it is going to be an ongoing challenge because, of course, there's a need for RNs nationwide right now. So,
yeah, I absolutely agree. And I just want to echo that working with people with mental health issues and substance use issues, especially like, say, for instance, here at the Access Center, that involves some really attuned skills to help individuals who are in those type of crises. And that takes an individual with good experience and the ability to be able to do that, and a lot of training. Recruiting, retaining individuals to be able to work at places like Access Centers or across the spectrum for mental health is definitely, it's a need. It's a great job, but like I said, it absolutely requires special skills and the right people to fill it. And here at Guidelink Center, for instance, how we're impacted is we're only able to operate at a third of our capacity right now, for the most part because of staffing issues, just being able to hire and recruit more staff. So it's definitely impacting the mental health system. I'm hopeful that some of the conversations around this will help us solve some of that need.
Yeah, for sure. And Andrew, I'm curious on your perspective there, because you talked about bringing in a clinician or somebody within the mental health world into the department. I think you maybe kind of have both sides of that, right? The challenge around officers themselves and from a mental health perspective. Just talk a little bit about your efforts there.
Well, I think since 2016, my department's been looking at a number of different co-responder models. And of course, there's a need to find funding to fund these type of initiatives. As we go through this period of restructuring, the opportunity to add a clinician is an opportunity that we've embraced. He's been with us now for a couple of months. He's currently training with his what we call his parent company. He's employed by Community Crisis Services, but he gives us an opportunity to enhance the type of response that we have to offer. Being able to utilize someone who's trained in crisis that isn't a law enforcement officer is a win for everybody. And he's still new. I make the statement, we're sort of building the plane as we fly it, but I remain extremely hopeful that this can be something that's extremely valuable to our community.
Yeah, absolutely. And Marissa, at the state level, what do you see from, when we think about bed availability, available staffing, what do you see at the state level?
Yeah, so, from our perspective here at DHS, we see it from two angles, because we see it, of course, from a policy perspective here as a state, where I can tell folks that I have conversations that somehow entangle in workforce about hourly right now. It's everywhere and all the time. It's a high level concern across the spectrum of care. The other angle that we see it from is we too provide care. We have state mental health institutions and state resource centers. We have to be able to take care of people too, and we're also challenged to be able to hire folks. So, one of the things that we're thinking about is we're trying to really think about how can we get to some root cause analysis and start to address some core issues. We want to do some work in our Medicaid reimbursement space, for instance, to ensure that our reimbursement spaces are hitting the right notes when it comes to how we pay for behavioral health care here in Iowa, and the other care that we provide under Medicaid as well. We also know that dollars don't seem to be the only answer, and that's because workforce has been an issue in the past. And so we have some idea that we can look backward and see what some of those solutions are. Often it's making sure that folks are confident and they're confident in what they're trained to do. They have to leave at the end of the day feeling successful. They need to be led by a leader. And so we're really looking for how can we support our providers who are out there doing their very best every day of the week, right? How can we support folks around some of those training pieces, for instance, and really make that kind of a space in our system potentially that we can all profit from, that we can all build from.
I would just add to that, yes, exactly. Dollars aren't going to solve all of the issues, and some of helping us change the approach or the culture around mental health staff and valuing those staff just as much as we do medical staff, I also think would be helpful as we continue to try to recruit and retain individuals into this field that I know we all know and love and feel invested in, but just helping them to feel valued and feel like they're making a difference as a whole.
Yeah, I think so too, Abby. And catching kids early, making sure they know that there's a true pathway. We've got a lot of levers, I think, and we just haven't always deployed them all together.
It's a sort of an interesting segue to kind of pivot a little bit, because we've talked in the past. Abby, maybe I'll come to you with this first. About kind of the maybe misconceptions or sort of the stereotypes around the connection between mental health or mental illness and violence. And I'm curious, when we think about people entering this field, talk a little bit about that connection. Does that connection exist? Are there misconceptions around that? And how does that impact that so-called stigma from a mental illness perspective?
Well, the short answer is yes, there are misconceptions surrounding that. The vast majority of people who have mental illness are no more likely to be violent than anyone else. In fact, they're more likely to be a victim of a crime than others as well. And with at least 1 in 5 people in our society having mental health issues, the likelihood that you know and care about someone with mental illness is very high. And I'm sure people know a lot of wonderful, highly productive people. Unfortunately, there are instances where someone with severe mental illness, possibly untreated, with environmental factors or co-occurring substance use, there could be a lot of factors there. Yes, they might be at more of a risk for having impulsive or possibly violent behavior, but that's definitely the minority. But of course, this is what seems to get the most attention in regards to, the entertainment industry or the media. Those stories are the ones that stick out the most. So unfortunately, that image that's attached to mental illness can create this stigma that's going to make people not want to, this negative stigma that's going to make them avoid or possibly delay getting the help that they need. So it's really important that we continue to fight against the stigma in relationship to mental illness and help people normalize, like I said earlier, that it's the same as seeking help for a medical illness. And it's important to look at it that way.
Yeah, if I could just jump in there, trying to train officers to acknowledge that individuals who are receiving treatment for the mental illness are no more violent than individuals who don't have a mental illness or a mental diagnosis. It's important for officers to know that as they look to offer, effective ways to mitigate whatever crisis a person's going through in the safest way possible. So education is a huge part of that. I think in an ideal world, mental health professionals would respond to deal with mental health problems. But it's important to remember that officers aren't seeking out ways to insert themselves into someone else's crisis. The reality is officers are being dispatched to multiple mental health calls, often on a daily basis, which means that someone connected to that particular crisis, whether it's a family member or an employer or a passerby, is calling because they need help to stabilize the situation. And they can't do that on their own, you know.
And I think it's so important too to emphasize the training to de-escalate if there happens to be a situation where an individual has become violent due to their mental illness. Yes, it doesn't happen that often, but if it does, being able to have that proper training, that proper knowledge, and the confidence of staff to be able to work with that individual to take it from a situation that is combative to bringing it down to a level where they can feel confident to get help. And so that's just a huge component of things too. So if they are come into that situation, they have that confidence available.
Yeah, I think. I apologize. Go ahead.
No, go right ahead, Andrew.
No, I was just going to say that I think again, I keep coming back to the ideal world. It would be nice if we could create a situation where law enforcement aren't relied on as much to mitigate some of these issues. But I think there are always going to be times when law enforcement are called upon to deal with that. So ensuring, I agree completely, ensuring that training is at the highest level possible, the officers are trained in de-escalation is hugely important.
It also makes me think about this is a strange sort of silver lining to COVID-19, that there's been a general nationwide lift in conversation around mental health, where more folks are able to tell their friends and neighbors that they're feeling anxious or they're feeling depressed. That's a movement forward that I don't think any of us would have necessarily anticipated coming out of a pandemic, but it's true. And so, it kind of is one of those pieces that gives us some hope as well. It's lifting up these conversations around stigma. It's getting folks to really acknowledge that, behavioral health is essential. This is real. That I think every bit of that conversation that we have kind of helps that whole spectrum as far as gaining the awareness, outside of training and the specific things around interventions, to your descriptions there, but just a national conversation even around what it really means.
I'm just going to piggyback off of you there in regards to awareness. As we all know, stigma is attached to confusion, uncertainty, fear. The more we can make each other aware of mental illness and, like I said, normalize treatment for mental illness, the more people are going to be likely to seek that help when they need it. So being aware, educating, I heard training, I heard all those words pop up in this conversation, can help with that stigma associated with mental illness. And then, we talked about how mental health issues and substance use is on the rise. We want people to feel comfortable seeking help. That's what we all want. So reducing that stigma is essential.
I'm curious, when you all four talk about kind of the education piece and how do we get that message out there, I think you each bring really unique perspectives. Andrew, you talked about a lot of times the first phone call that people make is to emergency services, and you're responding to those calls. So there's first responders involved. Ellen, from the behavioral health at the hospital standpoint, there's Marissa at the state level. There's a lot of different people involved, right? And I'm curious if you can talk a little bit more about that education piece and what do we need to do going forward so that everybody that's really involved in those different touch points can really provide the necessary services.
I can speak to a little bit of my experience working with various entities at Guidelink Center about that education and getting the word out. I think it starts with a mutual or a understanding and respect for what all of us are trying to do as kind of helpers out there, and being aware of both our strengths and our weaknesses in regards to the services and the things that we provide, and just kind of getting that conversation going. I think when people let down their defenses, they're much more willing to learn and to be aware and to experience not only what their world is, but what other people's worlds are as well. So that's kind of a bigger picture idea for me. That's not super a specific idea, but I just think that's a good place to start.
When I think in regards to education for the general public, to let us know what's out there, that removal of the stigma of seeking out resources for mental health is huge. I, for example, just the other week was part of an event at a high school where the focus was around mental health awareness. And it was fantastic to see all of these teenagers coming up to me and talking about the resources that are available. And I have this friend who, or it's me, or, and telling all these stories. But it was sad that as I was packing up and in the parking lot, I had individuals approaching me saying, why didn't anyone just see me talking to you? But this is what's going on with me. And that was hard to hear. It was wonderful that they took the time to come up and speak to me and to learn about what's available. But I hope that as we move forward and that stigma is taken away, there is more people in the general public who are willing to go up and just ask simple questions about what is available, if not for themselves or for a loved one. Not be afraid, not be embarrassed to do that.
Yeah, from our perspective here at the state, we do think about these sorts of things a lot. It's part of our job. We have to message this, and so we think about there's some marketing pieces. For instance, we talk about Your Life Iowa, and it's the number that folks can call to be able to access some support around behavioral health. We also work directly with a lot of different stakeholders in sometimes in stakeholder meetings or panels like this. We've worked really, really hard over the past couple of years in particular to have a much more transparent approach from the Department of Human Services to purposefully find places where folks want to talk with us. And then we share what we know, but we also make sure to listen, because that is the work. I mean, when we think about trying to fight stigma on a macro level, part of that work belongs to us. And it's really kind of a zoom in, zoom out space. Having a message, carrying it forward, and then helping people. In our Children's State Board, for instance, we've sat as a state board together and done some work around developing an elevator speech so that the members of the Children's State Board can go forward and in 30 seconds or less tell people what they do. And that's some of those things that we can do at kind of any level along the way. So we definitely have an interest there. We think that it's important. And we also think that as we kind of look forward to the future, that we're kind of primed to continue to do even better work in some of those spaces around, unifying our messaging as a state, really carrying forward that behavioral health is essential care, and really trying to strategically engage segments of the population that have maybe been underrepresented in the past.
And I think for us as a law enforcement agency, we want service providers to be part of to come to see what it's like in the law enforcement world. We have a ride-along program that many service providers have taken advantage of, which I think has been really, really beneficial in a number of different ways. One of which is just the dialogue that takes place during that period of time between the service provider and the law enforcement officer has been really valuable. As I say, so we want folks to be in our building, and we want them to see the complicated job that we do, in the hopes that they will have confidence in our ability to do that job. And it's just to develop a different understanding of law enforcement, and as well as the law enforcement officer having an opportunity to speak directly to service providers so that they can better understand what their role's like. That's the way forward for us as an agency, for sure.
Andrew, sorry, go ahead, Abbey.
No, I was just one more comment off of what Marissa said. She spoke of strategies at a macro level. I just wanted to add that at a micro level, the conversations that we have with our friends and family every day, and our children especially, those conversations are very important. When we use terms like "that's crazy" or "you must be insane" or "take a pill," I'm sure everybody's heard these thrown around. Understanding that even those micro level conversations have a ripple effect throughout our society that makes, again, attaches that stigma to mental illness, and then people are less likely to seek out help. Ellen, you brought up that example of someone coming up to you afterwards. My guess is that they didn't want to be called crazy or something like that, or made fun of.
Exactly.
So just wanted to state, I agree with everything everyone's saying, absolutely, but also the importance of just the day-to-day interactions we have with people, reframing some of the conversation around mental illness, and teaching, educating, and making even our loved ones and children aware.
It is a really great point. Thanks for bringing that up, Abby, because I do think that's hugely important. And Andrew, I was curious from your perspective. You talked about connecting with the other, mental health providers across the communities. And when I think about if I'm someone in need, or I have a loved one in need, and my first reach out is 911, and you respond, or someone within the department responds. Certainly, there's been a lot in the news recently about trust between community, between individual, someone with mental illness, and our first responders. Can you just talk a little bit about that? How do we go about breaking down the barriers so that we can really build the trust factor between all of those different groups of people?
I think one of the things that is important to note is your law enforcement agencies need to be, I think, subscribing to a community policing model where they go from being just a badge or a uniform in a vehicle. They get out their vehicles, they get on foot, they meet the public that they're serving. The public deserves and expects to have a fair, impartial, empathetic, and compassionate law enforcement officer. I believe that that's an expectation that the public has. I think that needs to be addressed at the recruitment level, as agencies are looking to bolster numbers within the department, number of officers that they have. I think sometimes we hire, then we train. And I think that hiring practices need to be looked at to make sure that as our culture evolves and as the expectations of our culture change, we need to make sure that we are hiring men and women who are able to meet those the demands of those changes. These things, coupled with a willingness for the officer to communicate well and collaborate with community stakeholders. It used to be that it would be your command staff that would have those conversations, that would be in those meetings. I believe that the officer on the street needs to get more involved in collaborating with community stakeholders. And I think that ultimately that collaboration is going to be the key to better outcomes.
Ellen, how do you see that because I think you're in an interesting position where, somebody may just frankly just walk in, right? If I'm in need, or if I have a loved one in need. But from your perspective, what does that process look like when it really works? If I were to say, best case scenario, we have a system that really works for anyone in need, how do you see that functioning?
No, I think what's important is, of course, being available when we talk about the window of courage being small, when it comes to reaching out and finally saying, you know what, I'm ready to ask for help, because that's hard for people. And I think that's something that we do truly need to understand, anyone in this field. But walking in and speaking to that individual and being respectful of their wishes and their understanding. I've talked with a few individuals in the senior field, for example, who work with older adults, and they have a stereotype as to what a mental health hospital looks like. And I say it's a stereotype lightly because 30, 40 years ago, it was, some of that was true, of the white walls, white floor, and very sterile, just, all the images from all the movies that you see. And it's terrifying for them to walk into our hospital and rely on us for assistance. And I say, treat it like an interview. Treat it like, ask yourself, is this someone who I can trust with my care? And it's very important with our assessment and referral process That's the very first thing. They walk through the door. They're greeted with a master level therapist who's going to sit down and talk to them about their situation. It may not be a situation where they're appropriate for our hospital, but our staff needs to have the tools available to say, okay, you're not appropriate for our services, but let's see what is available. You did walk through our doors for a reason, and we need to make sure that you're having that help. But I definitely think that that's something that to really look at, is being as respectful as you can and really truly listening and not being dismissive of certain aspects of what they're saying, but really listening. So.
Go ahead, Abby. Sorry.
I was just going to add, when it comes to building that trust in our communities, I'm a counselor. I'm always going to talk about talking it out and communicating, because I think that's huge, and creating some safe spaces for people with a variety of perspectives to have either small or larger scale conversations, I think would be really helpful to building that trust and seeing some of those larger systemic changes. I think that we're looking for. There's always room to improve, but that starting point seems to be my theme here, starts with understanding each other's perspectives and experiences. And like I said, creating that safe space. I mean, I'm just going to throw this out there when it comes to, public forums or the media or whatever else might get involved in some of these conversations. That's what's portrayed to everybody. But sometimes some of those other conversations that take place on the side or take place in smaller settings, that's where some of the real growth happens, I think, anyway. And so just kind of going back to that, to have that trust, I think it takes a lot of conversation and experience. Good, positive experiences is what needs to happen.
Yeah, Abby, just to echo so much of what you're saying matches up to so much of our experience here. We've been making that concentrated effort to have both large and smaller conversations. Some folks know that our DHS director and the interim public health director is Kelly Garcia, and she's been on what we're calling a summer tour. Even we're going out and visiting with providers and seeing people and having those sort of conversations. I've gotten to tag along for quite a few of them. It's been such a wonderful experience, in part for me, just personally, because I come from a background of delivering care. So it's just nice to see people in real life, not on screens. But it's also because we get to learn so much, and one of the things that's coming up for us so often, and I've heard it threaded in what all of you said as well, is how important we are actually very strategic, I would say, in lifting up the voices of folks with lived experiences. We've often sat at stakeholder tables that really worked very hard to engage an array of providers, for instance, but we forgot to engage people with lived experience. And so making sure that we do that work when we're thinking about it from a policy perspective here, or whether we're thinking about, what's the right next step as a provider? How are we going to look at this service line? How are we going to redesign our intake process, whatever it might be, including folks with lived experience in those processes, is such a valuable space that I think that we can mine some real success out of.
Yeah, that's, and Marissa, I'll come right back to you, because I think Abby said something about systemic level changes and really looking forward to what's happening there. And I'm curious, Marissa, if I can just ask you, one of those big changes that I know that will be coming up here down the pipeline is the rollout of 988. First of all, just for the people on the call, can you talk a little bit about what 988 is, how it came about, and how you see that impacting our communities going forward?
I can. So what 988 is that effective next year in July on a nationwide basis, there will be a 3-digit number, 988, and that 3-digit number will be the access, regardless of where you are, to like the National Suicide Prevention Lifeline. So it's really, it becomes this tool ultimately for us to be able to easily message out to people and for people to easily be able to remember. So when they are in a behavioral health crisis, they easily know how to get to care. What do I do when the very first time that my child presents and we're in such a situation that I don't know what to do, or when my neighbor is, something's wrong and I don't know what to do. We're doing a lot of active work right now, Brian, in doing a statewide plan that's bringing a lot of stakeholders to the table, just like we're talking about here. To really think about how that collaborative effort looks for all of us going forward, because it touches all of these different spaces. We have to make sure that the messaging is right, that folks know that it's there, that they know how to access it. We have to make decisions about what it means for us in the long run here in Iowa. Like, how does it best function for us as a state? But we think that it has just some amazing potential. In the last 5 years or so, we've done a really good job here in Iowa of building out additional crisis services. We've made some strategic investments. We've built those services out at the local level. We've leveraged partnerships. One of the things that's been really difficult, though, is that we didn't necessarily give it a system to plug into. And so the services exist, but sometimes folks don't know how to get there. And so they call 911 and they get law enforcement. And so we really have to do the thinking and the building for how does this all work and kind of get us to firing on all cylinders. But the good news is that it has its great potential and it's going to go. So next year on July, it's like July 16th. I always forget the exact date because it's an oddball, but I think it's July 16th in 2022. It becomes real. And when you dial 988, you'll be connected directly. And what you hope to get to is that you really have a person to talk to, a place to get to. So a place to get the care and that someone's going to respond, that you're not just talking to people, but if you needed it, someone's going to respond. So that's like a mobile crisis work that we've been doing here in Iowa.
Which I agree is absolutely important because, I am currently leading a access center in the state of Iowa. So I, of course, agree how important access is. Knowing the right number to call, knowing how to get to the right place is so important because as I mentioned earlier, sometimes navigating our system can be really difficult, especially for individuals who are experiencing crisis themselves or family members. So having the ability to make a call or understand how to get the help you need when you need it is essential for our state.
Yeah, thanks for the background on that, because I do think that access, just the whole idea behind having access to the care and to the resources and support is huge. Andrew, from your side of things, 988 doesn't necessarily remove or eliminate the need for police involvement or first responders or emergency services either. Can you just kind of talk from your perspective? What does the rollout of 988 look like, and how does that maybe shift things a little bit going forward?
To be honest, I'm not sure how 988 is going to shift things for law enforcement. My mantra for a while now has been, how do we provide the public with what it is they want, which is to try and remove law enforcement from the equation when it comes to individuals dealing with mental health issues. I would like to see, I'm hoping that 988 will be positive. I think it will be. I'm hoping that it won't dampen the conversation, though, to look at other 911 diversionary opportunities and practices to try and see if things can be employed here at the local level, whether it's crisis dispatchers who are employed to monitor dispatch essentially and to divert calls away from law enforcement that don't require law enforcement involvement. My hope is that there's room for both of those initiatives. And maybe Marissa could speak to that. I don't know her thoughts on that.
No, I think I would agree with you. I think that is the hope, that there's room for all of it. And the other piece that has been good in this process is that folks, both from the state level and the local level that have been active in the 911 space, have participated as stakeholders in that collaborative effort around building 988. And so the really good news component of that is that we have 30 years of experience in 911. And they were able to say, basically, do this, don't do that. That sort of thing, which becomes really informative for how do we think about 988 as a system plugin, and how do we make sure that we really bold the lines of connection, because once the messaging goes, because it's a nationwide initiative, so once the messaging goes, folks are going to start to dial 988, and right away, day one, we have to make sure that if that call comes through, but it actually needs to be with emergency response in the 911 space, for instance, that connection has to happen right away. And on the flip side of it, it also becomes, I think, that tool, just like you're talking about in the 911 space, if what they actually are needing is more of like that connection, right? A connection point, or help us with the mental health crisis side of things, there's a connection point there between the 911 systems and 988. So I think you're right. I think it's all of it. I really do. I think we need all of those things.
And one of the other things that I've heard a few of you touch on is this concept of access centers. So even, we have 988 rolling out, but then we also at a state level have 6, Marissa, I believe, coming on, access centers. Can you just talk a little bit about what an access center is? Why are they so important going forward? And what does that look like in terms of how someone in need can actually access the care that they're in need of?
Yeah, I can talk about it from the high level, but I want Abbey to tell us about what it looks like for her in real life. So I'm going to try to keep it short, Abbey. So access centers carried forward for us here in Iowa as part of a legislative initiative. And to your point, Brian, initially in legislation, we said 6. There was a committee of stakeholders again that sat together at the table and really talked about what some of these crisis needs were for us here in Iowa. And as they had those conversations, they really honed into needing this unified space to be able to respond to an array of behavioral health needs and really help us to divert people into the right spaces. That was really our hoped for outcome in access centers, was to make sure that folks had access to care, to, like you keep telling us, Abbey, rather than kind of circulating through the wrong paths, right? Repeating over in Ellen's ER or getting picked up by local law enforcement over and over and over again. We feel like access centers are such a key component to the crisis service array. So we've had some good success in standing them up, along with some of the other crisis services that were built out of some of those same initiatives. And we've been able to learn along the way some of the pieces that are working really, really well for us. When we look at the state right now, I think we're going to see more coming online simply because right now we have some concentration to the kind of eastern half of the state, but a little bit less to the western half. So we want to be able to catch some things over there too. We also still have conversation happening in the state of Iowa around how do access centers ultimately look for us, because we're in an implementation phase still. That means that sometimes you're going to learn pieces that are working or maybe pieces that aren't quite the fit that we thought they were. And one of those pieces is that we never defined an access center as a bricks and mortar space, for instance. Now, right now, everything's bricks and mortar, right? We've stood up places that people go. And that's often how people think of it. But we did leave it open to the idea that it could be a virtual connection, right? The idea that we are able to virtually connect to care and get to the right spaces from that sort of approach. But we haven't seen it actually in real time yet. So we haven't had a great opportunity yet to evaluate how that works. Our hoped for was that, especially out in some of our rural areas, leaving the door open for virtual connection might expand some of our coverage areas. But without the opportunity to see it, we're still in kind of an implementation phase. So like I said, we're excited to see the access centers coming online and to see the hard work that folks are putting in. I've had the opportunity to get out and visit some, and the work has really it's been fantastic over these past couple of years in particular. And Abbey, I want you to, and I'll stop there because I want you to be able to describe more about what you guys do there.
Yeah, thank you. I'm really proud of what is happening with access centers in the state of Iowa. And I can, of course, speak particularly to Iowa City where I'm at. But luckily, I'm able to meet with other access center directors and staff across the state to talk about what we're all doing. And essentially, it does provide that holistic, merging some services together type of approach. And in some areas, we do it a little differently than others. But here at Guidelink Center and like in Lynn County and Cedar Rapids, we actually have several services under one roof operating together, and you get to see some of those silos that sometimes occur between mental health services and substance use services be broken down, which is amazing because many of the people we see have co-occurring disorders. So when someone's able to come to Guidelink Center, they cannot get just but one, but two, maybe 3, 4, 5 needs met. And it's so essential to help have those positive outcomes. So access centers like our center here in Iowa City open for 24/7 walk-ins for anyone experiencing a mental health or substance use crisis. Access centers are not designed to replace any of our existing crisis tools we have in the community, including mobile crisis. Mobile crisis can still meet people where they are at in their homes in various areas in the community. But sometimes individuals want to come to a place where they know that they can get that access to that immediate level of care. And what we're noticing here in Iowa City working with area police departments, when they are dispatched to a situation where there is a mental health or substance use need, they will actually transport that person to Guidelink Center, and they have that option now. Access centers are creating another option for not only people in our communities, but for community providers. I've worked in community mental health for about 20 years, and so often on an outpatient level or in supported housing or other areas that I've worked in, our only option sometimes if someone's experiencing a mental health crisis and we can't wait 2 weeks, 2 months to get them in to see a doctor, was the ER. And now we have access centers that provide that intermediate level of like urgent care. Like if you think about urgent care medical centers, we provide that same level of care, but for mental health or substance use issues. So we have people who can come here rather than go to an emergency room, which I think is especially important right now during a pandemic to avoid unnecessary emergency room visits. Or like when we work with law enforcement, instead of them, if they're experiencing a substance use issue and, might otherwise get a public intox. I don't know, Andrew, if you can speak to that. This is an alternative with a sobering unit with substance use treatment here. Individuals don't have to go to jail. So I think access centers, you can tell I'm a fan. I think they're an essential part to our healthcare and behavioral healthcare substance use system in the state of Iowa. And I would just like to see them continue to expand. A lot of us are just getting started with access centers. There's so much more potential there, but we can already see with that ER jail diversion, seeing people get that immediate need met and avoiding any kind of or other possible kind of negative outcomes. Not even to mention the cost savings to our system when we have ER diversion. There's a lot of wins with access centers.
Well, just to jump on to kind of echo what you've said there, from a law enforcement perspective, to have the Guidelink Center in our own backyard has been great in terms of providing officers with more solutions and more resources. I mentioned earlier I teach on the crisis intervention team for the crisis intervention 40-hour program. And one of the, for the first couple of years, I couldn't help shake this feeling of we're providing officers with all these skills, but we've got nowhere to take them. When we encounter the client, so to have options that are truly diversionary, diverting from jail and from the ER is a great resource to have in our community. And but that being said, I mean, we talked a little bit about staffing issues across the board and across the country. With that comes a little bit of frustration, because things don't always go the way you hope that they're going to go. But largely, I can say that having Guidelink in our community has been, I don't use the term a game changer very often, but it really has been a game changer. And as staffing issues improve across the board, both in my agency, Abbey, and in yours, I really think it's going to be great.
Yeah, and to take that maybe even full circle right back to the very beginning, Ellen, we were talking about this continuum of care. When you think about all the things that the resources that are coming online, the rollout of 988, opening of access centers, all the things that are already there when you think about the behavioral health hospital, mobile crisis, police departments, and emergency responders, with all of these services out there, what does that continuum of care look like going forward? And how do you see that playing out if I'm a person in need or I have a loved one in need? What do I do?
I mean, I definitely see that it will be an uptick in success for individuals who have mental illness that are seeking or able to access the proper treatment for themselves. But, I think what's great is having all of these options and having that sort of no wrong door theory, if you will, of being able to go to the access center, by being able to go to Eagle View, calling 911, etc. Either way, you're going to somehow get help and somehow get connected. And so I think that's something that, as we move forward with all these great resources of keeping that in mind, there is no wrong door. Somehow you will be connected to the proper resource.
We do have a good question that just came in. Speaking of being able to get connected to the proper resource, The question, I'll just read it here, says, are there therapists that know how to work with children with developmental delays, cognitive impairments, or disabilities? And I'm curious, I guess along with that, I'll add my own side note to that. For those specific types of needs, how do I figure out where the proper care lies, and where do I need to go with that? I'll just toss it out to the group.
Go ahead.
Oh, sorry, Abby. I'll go first. But so the answer to the first part is yes. The question that I would tag onto the end of it is a question that's maybe, and are there enough? And the answer there is less clear. So one of the things that we know from some of what we can see from a state perspective is that there are certain needs that rise up for that group of folks. When I talked earlier about some people that get stuck in emergency rooms, for instance, with no place to go. And one of those groups are individuals in general, but children in particular, who have highly complex needs. So comorbid conditions, a serious or persistent mental illness, a serious emotional disturbance, alongside intellectual and developmental disabilities. That's one of the pieces that does rise up for us, or folks that are displaying aggressive behavior, for instance. So we definitely need some work there and some specialty care. How do you find them? That's also a little bit more difficult. The best resources for folks are going to be to look to their experts locally. And often our experts can start to help guide us in a kind of shepherding path through the system. And that really is the best way to go. I think sometimes when we're reaching out and trying to find care, we're just going to kind of reach out in all different directions and really look. But the best places to look, I think, are to the local experts and like, to Ellen and to Abby. In your local areas, you usually have line of sight on who's doing this work and who's doing it really great.
And I was just going to note to add to that, what you're describing is what I would consider somewhat of a complex need when you have multiple conditions that might require specialized type therapy. And I will echo what Marissa said. It's not just a question of finding it, but is there enough? and sometimes there's not. There's waits to get in to see somebody if you can find someone that offers that specialized kind of care. And I think as a group, and as in our community, we need to have even more discussion about those individuals who have those complex needs and where they're ending up, because sometimes there's not a therapist that can see them, or say, for instance, we have an access center, but that's for adults. So finding some additional solutions for individuals who have co-occurring disorders or complex needs is definitely an area I think we could work on.
And I also will say, sorry, go ahead.
Don't go right ahead, Ellen. Sorry.
I was just saying, speaking to that, I think it's important for us to reach out and realize what our service line is and what we are capable of, but also what we're not capable of at the current time, and being able to reach out ahead of time and saying, okay, so here's this whole of the service that we may not be able to provide, but I know someone's going to be calling, so let's get on it and let's find out who is available within that service, and trying to be proactive with finding those resources.
Yeah, that's a really good point. We've got about 5 minutes left here. I want to pose kind of a big picture, looking forward question, if you don't mind. Looking at where we're sort of at right now in terms of rolling out the resources that you all have talked about, 988, the access centers, all the great things that you're each doing from the behavioral health standpoint, the police department's work on this. First part of this question is, where do we need to go? Where do you think is sort of the next step? What makes the most sense? And then two, for the people listening on this call, what can we each do individually to try to make an impact when it comes to the mental health and well-being of Iowans in general? I know it's a really broad question, but.
I mean, I think in sense of awareness, it's important to try to seek out, events or organizations that may not be, that are kind of non-traditional. For example, I actually had a local tavern in Davenport. It's actually one of the original LGBTQ bars in the area reach out and say, is there any way I can get information from you? I worry oftentimes about some of our customers. And I thought that was incredible. You know, you wouldn't think to go and to reach out to a bar and to give our behavioral health information out there, but just looking to that non-traditional. And I think that also helps with taking away some more of that stigma where, you know, all of a sudden you're in a restaurant, but that information's right there for you. So it's not just, you know, direct and has to be that Google of behavioral health, but it's right in front of you in everyday living and being able to see that there is assistance out there.
You know, the things that come to my mind at an individual level, and this is an echo of what you were just describing there, Ellen, I think, and it's just that we can really continue to have courageous conversations, you know, that, you know, to really, and in a really direct and really kind way, address stigma when we see it, you know, and really continue to have those conversations in very open manner, and carry it forward. That's the work of one, and we can all carry that forward and kind of create those ripples. You know, when I think about some things from a macro perspective, I guess, you know, kind of from that systemic space of where do we go next, like you said, Brian, you know, I think that we consistently have to keep our eyes on the prize, which really is this ideal space, which is a no wrong door access system where folks are directly linked to the care they need at the right time and in the right place. You know, that's what we're all striving for. And that's the work that moves us forward. You know, defining the steps along the way is harder work. I mean, you know, we can articulate a vision all day long. We have to operationalize the work as well. But we have to keep our eyes on the prize to get there.
I think for me, it's continue to work with law enforcement and continue to welcome them into the mix when these conversations are taking place. I feel that when we work together, when we collaborate, when we truly enter into partnerships, that ultimately leads to the best outcome for the individual. And so I just would like to see that continue.
Same sentiments for me. Continue the conversation, continue collaborating, and to spread awareness, and to take some good forward-thinking, strategic type steps to affect change in our system.
Yeah, it's really great. When I hear that, and you hear the term collaboration a lot, when I think about who we have just in this group of 4 panelists and the work that can be done and the conversations that can be had in terms of the real impact going forward by all the things that we are already doing and that we're looking forward to doing, very much appreciate that. And I think that's the beauty of this whole dialogue, is that we can continue that work. So Ellen, Abby, Andrew, Marissa, thank you all so much for being a part of this. I think it's a hugely important conversation. And looking forward, I think there's a lot of work that continues to be done, and that is very exciting in terms of what the future has in store from a mental health resource and support perspective. So thank you so much for being a part of that. For the audience here, a couple of quick notes for you. 8:30 tomorrow morning, we'll kick off again with another major keynote speaker, Thomas Apps. He's the author of the book Bleeding Out, looking at urban violence and some of the trends, research, and what can be done there. We'll have a full panel around that as well. That'll be followed by some additional panels, additional sessions, and then we'll actually have a closing keynote from astronaut Peggy Whitson tomorrow afternoon. That will be followed again even by some more follow-up sessions on what can really be done tangibly and how can you all get involved. So looking forward to that. Thank you everybody for sticking around with us this afternoon, and hopefully we will see you all tomorrow. Thanks everybody.
Thank you.
Thank you.